إن شاء الله نبدأ بإذن الله. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. Hello everyone. I hope you are well. I am very honored to invite my colleague Dr. Ammar Ali, nephrology specialist in Niswa Hospital. Dr. Ammar is have got this year European specialty exam in nephrology, and also have deceased donor transplant certificate from World Kidney Academy 2024. Also, Dr. Ammar have high study certificate in nephrology from Syria 2017 and the Syrian board in nephrology 2015. As we know, regarding common problem with BD is decreased KT over V and volume overload, which are the main part with time for BD initiation. Dr. Ammar today will talk about strategies for volume management in BD and how we can change BD prescription by transporter characteristics. Please, Dr. Ammar, you can start.
Assalamu alaikum. Shukran, Dr. Ahmed. Thank you very much. Good evening, everyone. I'll start sharing my slides. Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. So as Dr. Ahmed mentioned, today we will be focusing on optimizing BD prescription for volume control. And volume control, as we know, is a delicate balance. So my objective will be to develop a tailored BD prescription for common clinical conditions, assessing volume status in BD, strategies for volume management in BD, and we'll have more of case scenarios and clinical decision-making processes. Finally, we'll apply a structured diagnostic approach to the patient with ultrafiltration failure. So regarding BD prescription, how to start? The basics actually, to understand more better, to take a clinical scenario, like we are seeing in our clinics, in pre-dialysis clinic, we have like a patient with diabetes, hypertension, CKD stage 5, SGFR now reached 11, started to be hyperkalemic, acidotic, and he have lower lymphedema, BP on the upper limit. Good that he still have urine output. The patient was counseled for kidney replacement therapy and she preferred to be on BD. So think of BD catheter was inserted using a peritoneal technique. After that, as usually, we are giving the patient rest for 2 weeks without dialysis, but we are doing weekly exit site dressing and BD cast flushing at the BD clinic as outpatient. After the patient completed that 2 weeks, she was admitted for BD initiation and training. So how we'll start? What's the prescription will be? Actually, we give the patient an idea about each modality, even BD modalities, before starting dialysis, and after insertion, we'll give him an idea what's the options we have. And then according to the patient preference, we will choose the modality. So for the beginning, we have either ABD, automated peritoneal dialysis, or ambulatory peritoneal dialysis. Automated peritoneal dialysis, ABD, using cyclers, machines, used while patient is sleeping nighttime. It allows for clearance and effective UF with frequent exchanges. We can control this by the cycler, and it's favorable for patients with busy daytime schedule, like students or who are active working, who want to skip the daytime sessions or exchanges and do the treatment nighttime. Sometimes who will choose is the caregiver, because the patient sometimes is not able to do the treatment, so his caregiver will be the responsible. So ABD allows us for utilization if available, if there is training capacity, and according to the local resources. The other modality is a manual or ambulatory one, continuous ambulatory BD or CABD. Here, the patient is good for patient who does not want to be connected to machines or cycler during sleep. He feels this machine will disturb his sleep. And this is good for patients who are flexible in daytime schedule, patients who want to travel frequently without the need to take the cycler every time, and it have higher use in low resource settings. CABD is done daytime, 3 to 4 exchanges, depending on the clinical status. So now we have the idea to choose either ABD, automated, or the manual one. What's the next step? Here we have the concept of incremental BD. It's good at starting the treatments. We'll start with low dose dialysis, increase gradually as the residual kidney function declines. It's good for the patient. It will reduce the burden of treatment at the beginning. It will improve his quality of life, and it will give the patient time to become comfortable with the therapy. It allows us to tailor the BD prescription with focus on laboratory investigations, clinical symptoms, and the patient preference. So in this modality, we'll start with low dose and increase gradually. But there is, as usual, there is drawbacks, as we need here to do frequent monitoring of residual kidney function. There is a risk of underdialysis if there is delay in adjustment the prescription, and there is decreased patient acceptance later on if we want to decrease the dose. So from the beginning, we need to explain the patient that this is the initial, maybe later we need to increase the dose more. So how to do the incremental BD? We'll start with ABD. We'll initiate like 2-3 cycles on the cycler, 6 to 7 hours nighttime, and with low full volume, 1.2 to 1.5 liter with this cycle. And we will use a low concentration of BD solutions, like dextrose 1.5 or combination 1.5 and 2.5% dextrose. Then later on the follow-up, we'll adjust the prescription based on laboratory investigations and clinical assessment. In CABD, almost the same, we're using 2 to 3 exchange, but here this is manual, done on daytime. The fill volume also low volume, 1.2 to 1.5 liter with each exchange. And we will use the low concentration of solutions like 1.5% exclusively or combination of 1.5 and 2.5 BD solutions. We are speaking about dextrose. So this is a chart for the incremental BD. First, we'll choose the modality. Is it automated or manual? If automated, the cycler, 2 to 3 cycles, low concentration, low volume, and daytime it will be dry. In manual or CABD, we'll start 2-3 exchange daytime, low concentration and low full volume. Then assessment of the patient and revising of the treatment accordingly. What are the adjustment steps? This is a stepwise approach, how to adjust the prescription or increasing the dose of BD. According to the problem, if you have suboptimal solute clearance, then the first step is to increase the fill volume 20 to 30% up to 2 liters, and above it will be not that much effective, but it depends on the patient body surface area. Then next step is increase number of exchanges. And when the volume is maximized, we'll do this step. Then the third step, if ABD cycles, fill volume maximized, number of cycles maximized, we will consider a daytime long dwell with icodextrin. If the problem with the patient is volume overload, this is somehow different approach. We need to look for the residual kidney function, maximize diuretics, ensure salt and fluid restriction. If not used before, we will use icodextrin. Adjust the duration of dextrose dwell according to the membrane type, and consider more hypertonic solution as the last step after we did all the previous steps. So here's the type of BD, nighttime or daytime. ABD starts only nighttime, which called ABD we are using as, or NIBD, nocturnal intermittent BD. We start like 3-4 cycles maximized. After maximizing the number of cycles, we will add a daytime dwell of icodextrin. Then later we'll speak about how to maximize the dose rule. FCABD will start daytime, 2-3 cycles, or 2-3 exchanges we call it, and the nighttime we can, if needed later, we add icodexin. What's the role of PET? We know that PET test is done to know the patient transport solute type regarding, so it will help us on small solute and UF capacity by using equilibration between the peritoneal and the plasma. Repeated measurements, we are using instead of installation of 2.5% dextrose for total of 4 hours. This is a standard PET test used before as standard for all patients. But we have recent significant change in the clinical practice regarding the PET utilization. Now, it was historically like used to dictate the PD prescription. It was like mandatory to know what to start, ABD or CABD. But more recently, the choice is primarily driven by patient preference mainly, and clinical outcomes, then comes the finance. No longer we in our center, and we know many other centers, they no longer they are routinely perform the PET for BD patients. And this is what like a significant change in the clinical practice recently. So as our focus or today's scope of the session will be on the volume control. So why volume control matters? Actually, it's highly prevalent. 50 to 70% of BD patients have volume overload and have many consequences like resistant hypertension, LVH, increased hospitalization rates, and higher all-cause and cardiovascular mortality. What the ISBD guidelines tell us about volume status? It stated that high-quality, goal-directed BD prescription should aim to achieve and maintain clinical euvolemia, taking residual kidney function and its preservation into account, and clinical examination remain the keystone for routine clinical care. How to assess the volume status? Mainly by physical exam. Weight gain, we have serial weight check in our clinics. We'll follow up blood pressure, jugular vein distension, chest examination for heart examination, and peripheral edema. But we need to be careful about peripheral edema. It should not be taken alone. If the things are not clear or need additional supplementary tests, we can use bioimpedance, lung water ultrasound, IVC ultrasound, and BMB as blood test. So to know how to manage the volume overload MBD, we need to categorize the causes. So it will be like a causative treatment. So the main cause will be either increased intake, reduced residual kidney function, or inadequate peritoneal ultrafiltration. We will try to make it easier by taking clinical scenarios, what we are seeing daily in our practice. Like this patient, 40 years old man, end stage due to diabetic kidney disease. He is on automated peritoneal dialysis for around 1 year. His prescription is ABD or NIPD. For 9 hours, he's doing the cycler. For 5 cycles, the fill volume is 2 liters, using 1.5 and 2.5 dextrose. He came to the clinic on Sunday morning. He's feeling unwell. He noted that there is 3 kg increase in his weight, and from last week only. His blood pressure was high, and so his blood glucose. We noted his UF record from BD sessions. It was on average about 1.2 liter per day, which is good. And he still have good urine output around 1 liter. So where is the problem? Where is the defect in the system? When we asked the patient, he reported that he have a family trip outside the governorate for 2 days. He have barbecue party on Friday. He consumed a lot of salty food, juice, and coffee. So here is the defect. It's the intake. So all the patients should be counseled to have salt and fluid restriction, good glycemic control, and to be compliant with their BD sessions. So here's the first cause of volume overload in the patient, BD patients is increased intake. It's the first step in management volume overload. should be good counseling about salt and fluid restriction. The advice is dietary sodium intake less than 2 grams per day, fluid generally less than 1.5, and then patients we have who don't have residual kidney function or urine output less than 1 liter may be needed, even it's difficult for the patient. And the other issues for management of hyperglycemia, because hyperglycemia will make the patient thirsty and he will consume more water. Another case scenario, 72-year-old man, he's on CAPD, ambulatory manual PD, for around 2 years. His current prescription is 4 exchanges, daytime, 2 liter, each cycle or exchange, and he is using dextrose 2.5%. Over the past 3 months, the patient reported gradual increase in his weight gain with high blood pressure. 24 hours urine noted to have decreased from 800 to 250 ml per day. So you have clear cause. The patient have loss of residual kidney function, which was contributing to his volume and sodium removal, and that tipped him to volume overload. So what's the next step in management? In this point, we need to maximize diuretic dosing, optimize his BD prescription to compensate for the loss of his residual kidney function. Here at this point, we can for him icodextrin as nighttime long dwell, if not used before. So here the second part of the cause of volume overload is the residual kidney function. Actually, residual kidney function is a single best predictor of survival in BD. It contributes to both solute clearance and volume control. The approach to be if the patient have urine output more than 100 ml per day, need to maximize the diuretic dose using loop diuretics like furosemide up to 400 mg per day in divided doses. Metolazone you can increase up to 10 mg per day. And spironolactone can be added in patients with hypokalemia to maintain normokalemia if the patient was higher from other diuretics. What other strategy can be done to preserve residual kidney function? We can recommend it to use ACE or ARBs. It may be protective. Avoid nephrotoxic medications, non-steroidal IV contrast unless highly needed. Use of biocompatible dialysate, use of dialysate with low concentration of dextrose, and avoid excessive intravascular volume depletion. This is the other side. Avoid the volume depletion to preserve the residual kidney function. Let's take another clinical scenario. A 70-year-old man reported that he have 2 nights his cycler has been alarming, too much alarms. The alarms on the machine showing low drain alarm. He feels more bloated and he has gained 2 kg. His BB is high. We did in the OBD, we did BD catheter flushing, smooth inflow, but the drain was poor. Actually, he reports some new constipation, but he denies any fever, abdominal pain. So there is no signs of peritonitis. We ask it abdominal X-ray. We see this feature. It's clear that the patient have its loaded colon, the patient is constipated, but the good thing here is that the BD-CAS coil still in the pelvis. So the patient is having constipation, it's causing his low UF. Here the management will be to initiate power regimen like polyethylene glycol, bisacodyl, lactulose. Lactulose not preferred in old and immobile patients, and dietitian counseling to solve his constipation. Another patient, also old man on CAPD, he had post-surgery for left femur fracture 3 weeks back. He is bedbound and suffered from constipation recently after surgery. And also he reported that he have the drain issue with the drain, persisting feeling of fullness. His net ultrafiltration has been negative.